arterial blood gas analysis, and the other is on mechanical ventilation. Apart from his regular hours at different medical colleges, he also does a lot of social service, being available at 2 locations which are for underprivileged children, women, and men. He's also the chief editor of the Journal of Medical and Allied Sciences. He's formerly been on the editorial board member of CHEST, more than 70 papers, more than 400 citations, more than 400 invited lectures. I think you can start, keep reading, and the whole thing would, my introduction itself may turn into an oration. Oration on Dr. Swarna.
Thank you very much, Dr. Ghanshyam. To begin with, critical thinking can get you into a lot of trouble. And the man that you see on the screen is Socrates of Athens. And this man had a habit, whenever he got into an argument, he would ask very short questions, which required very brief answers, either yes or no, or something very brief. And at the end of the conversation, his adversaries usually found that they had painted themselves into a corner and had no more answers left. So Socrates didn't win any popularity contests. In fact, he didn't endear himself to the rich and the powerful with whom he came in conflict at some point of time, and he was framed and finally executed by giving him a cup of poisoned wine, hemlock, as was the custom of the day. But before he passed away, he had established a standard of sorts. For 2000 years, even 2500 years later, can you control it from there, please? Yeah, okay, all right. So even 2500 years later, there were no better approaches to critical thinking, because Socrates found, he examined the assumptions, he disregarded the beliefs, and he took the evidence. And he said that framing the question should be directed and purposeful. The objections to the questions should be tested. If the objections were found to be valid, the questions should be revised. Again, the question should be directed and purposeful. And again, the objections should be tested, and so on and so forth, until the objections were relegated to minor and the premise survived. So his style of reasoning came under the category of rational thinking. But today, as we know, we have begun to practice something called evidence-based medicine. Now, you might think that it is not in conflict with rational thinking intuitively, but that's not the case. Evidence-based medicine, in fact, relies a hell of a lot on observation. What is the cause, what is the effect, and what is the unifying link between the cause and effect based on observation, not based on rationality, what you might be logical or thinking. So, in other words, observation trumps rationality. And this is what is today the practice of medicine, in contrast to what we did earlier. So we have, on one hand, there's a lag between this, so I'm a little, So on one hand, we have got facts and evidence on the left side. On the other side, we have got our own set of beliefs, which we have accumulated over a period of time as a baggage. But then, when you interpret the evidence, in the center, we have the evidence which is colored by our beliefs. In the ICU, where time is at a premium and action needs to be fast much of the time, the intensivists are under a lot of pressure. And how often have we found ourselves under pressure to do something, make a particular change, and then we had to wait because the guidelines said not yet. So this is called the action bias. You had a period of time where the cavemen were sitting around a fire enjoying their meal, and there was a sudden movement in the of shadows in the background, and they had to get up and run. 99% of the time they were wrong, but one time when there was a saber-toothed tiger in the background, they survived. So this is instinctive. This is why we are having an action bias. On the other hand, it is also frequently seen that many times when the patients are sick, you have a situation where the patient is sinking and is irrevocably in a state where he can't get better. And then he needs this absolutely required surgery, and the surgeon says, no, the risk is too high. He'll die on the table, but he's going to die anyway. So this is called as an omission bias. You are not operating because he's going to die, but because you're not operating, he's going to die anyway. So it's actually, life is full of biases in the ICU. There are about 180 plus biases in medicine. So obviously I can't go into that, we'll do it some other time. But I'll take you through into how we navigate critical thinking very, very briefly. So it's basically in two major ways of thinking. One is deductive thinking, where you proceed. Let's start at the theory. This is the term that was used from a long time. Aristotle was indulged in this kind of thinking. It starts from a theory, which leads to a hypothesis, leads to an observation, and then finally to confirmation. So studies are designed like this. It starts from broad generalizations to specifics, and generally the outcome is extremely accurate. On the other hand, inductive studies, if you look at the bottom, it starts with an observation. Then you see a kind of a pattern in these observations. Then you take it forward, build a hypothesis, you test it out, and then eventually you arrive at a theory. So it's in exactly the opposite direction. And perhaps, which I don't agree, it was indulged in by Sherlock Holmes. So it goes from specifics to broad generalizations, and the results are actually quite approximate. Now, deductive reasoning, as I said, is seldom wrong. It starts with what we call as syllogisms, which are presumptions which have great authenticity. So, for example, a person has acute dyspnea and consequently is breathing hard, and consequently his carbon dioxide is getting washed out. We know that. That's syllogism number one. Syllogism number two is when there is respiratory muscle fatigue, the carbon dioxide gets retained. That's syllogism number two. But if you have a person with acute dyspnea whose carbon dioxide is high, then you can surmise that this patient is on the verge of respiratory muscle fatigue. So this is the accuracy with which deductive thinking works. Most bald men are grandfathers. Ashok is bald, therefore Ashok is a grandfather. So sometimes it goes wrong. But if you examine it critically, the problem is that most bald men are not grandfathers. So your syllogism is wrong, not the process of thinking itself. So this is a brilliant book. I won't spend much time here. He won the Nobel Prize in economics for behavioral economics, how humans think. And he categorized thinking into two types: intuitive, rapid thinking, which we do most of the time, and more slow, deliberate thinking. But his book is not as shallow as that. It has a lot of depth and purpose, and I recommend it to every person. But the fact of the matter is, inductive reasoning depends on pattern recognition. And if you read from there, it's extremely easy to read this. I could not believe that I could actually understand what I was reading. This phenomenal power of the human mind, according to research at the Cambridge University, it doesn't matter in what order the letters are in the word are. The only important thing is the first and last letters be in the right place, the rest can be a total mess. So we are trained to recognize patterns. And if you look at the starting observation here, young individuals presenting with breathlessness to the ER, you have a huge number of asthmatic patients, and you have one patient who is either psychogenic or has pulmonary thromboembolism or whatever it is. So your inference is that young individuals presenting with breathlessness to the ER have asthma. And this generalization, which you have arrived at from a specific observation, leads to an explanation. And then you say, look, elderly people, the person is not elderly, doesn't have COPD, doesn't have CAD, therefore asthma is more rational here. So this is basically inductive thinking. There is another kind of thinking that's called abductive thinking. And abductive thinking is basically based on incomplete observations. And unlike deductive reasoning, where the specific conclusions are always true, inductive reasoning, where they may be true, in adductive reasoning, it is also likely that there is some amount of uncertainty about the inferences. So this was the world's greatest abductive thinker. And you can recognize from the silhouette it was Sherlock Holmes. Now, if you can read through so many of his short stories or indeed his novels, you can find that most of his impressions are instantaneous, based on the stain on the sleeve, or the dust on the boot, or the splatter of paint on some part of the clothes. He can make instinctive deductions. And the other people, other kind of people who do abductive thinking are us, as doctors. So you have a 80-year-old edentulous ex-smoker with recurrent pneumonia, CA bronchus, dyspnea with wheeze following dust exposure, asthma, hemoptysis associated with menstrual periods, catamenial hemoptysis. So inference is by no means sure, yet it's the most likely explanation and needs to be borne out by further testing. That brings us to the question, is medicine in part is an art? Because it's definitely a science, we know that. And this question was examined, not today, but many years ago, in 1954. But the book was so good that it was republished in 1996. And here, the object of intuition. To me, actually, I always believed that intuition was nothing but knowledge that was stored in the subconscious and that came out, whenever you met with similar situations. But apparently it's not so, and intuition should not be trusted. Now this is a patient of ours, 75-year-old lady, asthmatic, hypertensive, large exudative pleural effusion, no coronary artery disease. The pleural effusion is an exudate. Various things there, but overall good systolic function. And there was some subcarinal nodes and paratracheal lymph nodes which turned out to be red herrings. The most important clue here was she had disproportionate breathlessness, which was out of proportion to the pleural effusion that she had. And this led to a consideration that, she had an exudate, so we consider usual things, whether there was a mitosis there, or connective tissue disease, or even tuberculosis. But because there was disproportionate breathlessness, we thought that we should lend credence to consideration that it could be a PT or a CCF, in which case the exudate didn't fit in, and therefore we should revise the diagnosis to be a pseudo-exudate. And accordingly, we investigated. The BNP was found to be high, and eventually the cardiologist, finally confirmed on CAG that the things were not so great. So this is called basically alternative path to diagnosis. And obviously, if you have a cardiologist who makes a diagnosis of CAD, that's quite painless. But unfortunately, pulmonologists have been in constant conflict with cardiologists, where he says echo is completely normal, there's no cardiac issue here, COPD. But the pulmonologist thinks, look, non-smoker, no occupational risks for COPD, no family history, no atopic, blah, 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 no pneumothorax, whatever. It's either CTP, it's either PT, or it is cardiac failure. You do a CTPA, you find it's normal, you come back and very hesitantly make the request to the cardiologist, can we do a BNP, can we check again? And the cardiologist, sometimes he agrees, and then he goes ahead, and eventually it turns out to be a cardiac problem. So this is called alternative path to thinking. And believe me, it has worked for me many, many times. And believe me, it should not be disregarded because it's a very, very important part of critical thinking. Now, to get the right answers, you need to ask the right questions. And there are a lot of questions, and this is from up to date as anybody will recognize. But the fact of the matter is, how many questions can you ask? How are you sure that you're not going to miss anything, from the list of questions and therefore miss the diagnosis? So there comes the importance of etiological tables, which I value very, very much. I have a laptop constantly open, partly because my brain, doesn't keep pace with what the patient is thinking, saying, but also because this provides a very comprehensive checklist for the questions that you need to ask. Now, the thing is, we talk about classifications into etiological tables. But why do we classify? I mean, it's a no-brainer, but we classify because we need to put certain conditions into common areas of pathogenesis or treatment or even diagnostics. That makes us approach and understand things better. And indeed, why do we define? What is a definition? A definition is nothing but a description of a disease which is absolutely unique to itself. So these considerations will actually lead you to creation of etiological tables, and basically this is devised on the oxygen delivery. You can create subsystems. This is a physiological system. Physiological systems are really difficult to create because physiology is not very well understood. But you could integrate a physiological system with an anatomical system and make your etiological table comprehensive enough. So you can have at least a checklist or a working list for diagnosis later. So this is called systems thinking. And systems thinking basically is, if you talk about respiratory failure, you have type 1 respiratory failure, type 2 respiratory failure. Why? Why type 2 respiratory failure? Of course, now there are 3 and 4 as well. Why? The reason is, if you have type 1 respiratory failure, the problem is of gas exchange, the problem is inside the lungs. If you have type 2 respiratory failure, the problem is of bulk flow in and out of the lungs, ventilation, and therefore the problem is outside the lungs. And this generally works very well. In type 2 respiratory failure, your ADO2 is fine, your carbon dioxide is elevated, so on, and therefore you immediately it narrows the differential diagnosis, and you turn your attention to the circuit that eventually makes the lungs, the diaphragmatic muscles move. And indeed, it narrows the differential diagnosis pretty considerably. And on the other hand, if you talk about type 1 respiratory failure, here it is more of a physiological classification. And if you have, for example, a shunt where your oxygenation is not responsive to supplemental oxygen, then you start thinking if the X-ray is now abnormal, you think of collapse, you think of severe consolidation, or you think of a kind of a pulmonary embolism possibly. And if your X-ray is fine, then pulmonary embolism becomes a very, very strong possibility. So this is how you integrate the anatomical and the physiological aspects into your thinking. And as I said, that you have to, in type respiratory failure, the focus will also be anatomical. Now, these are the conventional classifications where, personally, I'm not very comfortable with this classification. Type 1 respiratory failure, I can understand. Type 2 respiratory failure, I can understand. But I become very uncertain when I kind of start thinking of type 3 and respiratory failure, type 2 respiratory failure. But what I rather would like to see is, if you're talking about a rise in fall in oxygen, your carbon dioxide is supposed to rise proportionately. If your carbon dioxide rises to a particular level, your oxygen is supposed to fall proportionately. But if your oxygen falls disproportionately, then there is something else in addition to a type 2 respiratory failure. Type 1 elements are intruding into type 2 respiratory failure, and I would like to call it type 3 respiratory failure. Unfortunately, that term is already taken. So I would probably call it mixed respiratory failure or type X respiratory failure or complicated respiratory failure or whatever it is. Eventually, let's say a person has type 2 respiratory failure due to sedative overdose, aspirates, gets a gas exchange problem, gets type 1 respiratory failure, which is out of proportion. That's what I call as mixed respiratory failure. Similarly, in severe asthma, type 1 going into respiratory muscle fatigue, type 2. So these are additive. Acute exacerbation of COPD, type 2, with PT in the background, type 1. So you have oxygenation falling out of proportion to the expected, rise in carbon dioxide. And of course, you have the universal classification, which almost never fails. Now, the next step is to shorten the differential diagnosis. And this is William of Ockham, lived near Surrey, was a monk, scholar, and this man, he invented one of the laws called Ockham's razor. He didn't have a razor. The razor was hypothetical, but he used to cut down the explanations for a particular set of clinical symptoms. So this is called the law of parsimony in medicine. Use as few explanations as possible to account for the symptoms. And this man was an expert. So actually that's exactly the exercise we take when we are confronted with a huge list of differential diagnoses. If you want to narrow the differential diagnosis some more, you need to introduce a second element into it. As you can see in the blue column, talk about decreased air movement or muscle weakness or fatigue. So in that sense, once you use two elements, the differential diagnosis gets shortened. But the most powerful way to shorten the differential diagnosis is to introduce a truly unusual element. For example, if you construct a differential diagnosis based on cough, you have hundreds of differential diagnoses. Same with expectoration, same with pedal edema. But if you introduce either a pulmonary nodule or telangiectasia into that, your differential diagnosis immediately gets compressed. So the approach becomes a syndromic one, and you have to just to tally these two things. But you have to be aware that the differential diagnosis, the thing is the so-called rare condition is actually a rare condition and not a red herring. And this was basically Hedwig von Restov, who formulated a Restov's law. Whereas your eyes immediately go to the red herring, or the red tomato, I should say. So you should not get distracted by that. Now, mind maps are very useful. I mean, we do it all the time. And not only do they give you insight into how the problem is and in relation to the other things, but they also give you insight into the possible treatment. And if you don't understand, or if I don't understand something, I always write it down, what are the issues that we're dealing with, and that somehow triggers the mind into giving a solution. So, talking about triggering the mind, this was a very useful, kind of a common study done in corporates, where if you're feeling down and depressed, you take a pencil and hold it between your teeth. That spreads your mouth into a grin. Now, your mind gets the feedback that things are good, man is happy, and accordingly it makes the required adjustments and your mood gets uplifted. Therefore, how does it apply to our situation is, if you use the right word, and this is basically not for you, it's for undergraduates, the mind is triggered into supplying a diagnosis. If you talk about an air bronchogram, the mind tells you it's consolidation. If you talk about a white infiltrate, the mind will say, okay, wait. But if you say air bronchogram, immediately the next thought that comes into your mind is it is consolidation. If you talk about a homogeneous peripheral shadow which is having concave inner border, no air bronchogram, pleural effusion. Disc-like atelectasis, subsegmental collapse, or even past pulmonary embolism, or things like that. So specific terminology leads to specific diagnoses. Now I'm almost another 3 minutes, I suppose, towards the end. 26-year-old housewife, 5 years ago presented somewhere else. Progressive dyspnea on exertion, one episode of pre-syncope, rest of things were more or less negative, but the echo picked up unexpected pulmonary hypertension. This was a chest X-ray, which we all agreed was normal. This was the CT scan, which we all agreed also was normal. This was the EKG, which showed RVH. And accordingly, a diagnosis of idiopathic pulmonary hypertension was made after exclusion of all the other causes of pulmonary hypertension. So that's very important. That's why it's idiopathic. And these were the kind of, the data there. No need to get specifically into that. So just look at exactly what's happening. Here, in June 2007, the estimated pulmonary systolic pressures were 80, 2008 85, 2009 65, 2011 46. IPH never gets better. IPH is relentlessly progressive. 2012, no PH. This is astonishing. So at this time, she was referred to us by a cardiologist, and this, without doubt, was the only time in my life I've been referred a patient because the patient is getting better. But the patient had a problem. Life-threatening diagnosis recently, married for 5 years, childless, keen on conceiving, but improving, and no diagnosis. So we reviewed the X-rays. We thought we saw something in the left mid-zone. We did another CTPA. And we found, if you can see there is a huge PA venous malformation, pulmonary arteriovenous malformation. And this was acting like a pressure cooker, the valve on a pressure cooker. It was decompressing the pulmonary circulation. So we published it. Unfortunately, the husband of the patient didn't agree, and we did follow her up over a period of time. She continues to be okay, but the lesion has expanded, unfortunately, after she underwent pregnancy. So this is also a kind of a curious incident of the dog in the night time. Is there any other point to which you wish to draw my attention? Holmes says to the curious incident of the dog in the night time. But the dog did nothing in the night time. That was a curious incident. So when you don't expect normality, if you find normality, then that's a red flag. And finally, this is a case from 1997. At that time, it was unusual. Today, all of you must be making these diagnoses. So this was a policeman from the district, developed a skin rash on the feet, was given some medications, including a steroid, came to us, bad shape, ARDS, and just before he was intubated electively, he had a massive bout of hemoptysis. Everybody said, bad intubation, stellate. But the anesthetist was extremely experienced. He said, no, I did a bronchoscopy, blood everywhere, lavaged it, cleared it, sent it to, at that time I was working in Medicity Hospital, Medwin had the only good lab there. We sent it and we had a diagnosis of Wuchereria bancrofti. Now this was the first ever case of Wuchereria bancrofti causing hemorrhage, or not. You have to revise your diagnosis. Does Wuchereria bancrofti cause hemorrhage? So this is basically, we spoke back to the pathologist and eventually she reconsidered, did some more testing and came back to us with a diagnosis of strongyloids. So this is called, these are my final slides. Common things are common. We all know that. So when you hear hoofbeats, don't think of a horse, don't think of a zebra, think of a horse first. And this adage was coined by Theodore Woodward at the University of Maryland, Baltimore. He did a lot of work on typhus and typhoid, 1948 Nobel nomination, whatever. And this also goes by the name of Sutton's Law. And Sutton was no researcher. He was no epidemiologist. He was not even a doctor. He was a bank robber. And when he was asked by a journalist why he robbed banks, he said, because that's where the money is. So this simplified, I won't say simplistic thinking, simplified thinking actually makes a lot of sense in where we practice. Where there's a lot of confusion, a lot of pressure on us, and this is actually one of my most favorite, the favorite quotation by the man who authored the famous book called Walden. I take this opportunity once again to thank all of you for giving me this unexpected honor. I should say unexpected because I can think of so many people there who are better deserving of this. However, I will take it because it's again a great privilege for me. I thank you for a very patient hearing, and I suppose no questions.